Excellent. Okay, so let's get started. I think there will be probably some people joining as we get started, but that's fine. So a warm welcome, and a very warm welcome if you're in certainly Canada or the US, or perhaps Hong Kong as well. Warm welcome, good afternoon, good morning, I think even good evening to at least one person on the call. I am very happy to be sharing this webinar with you. This is a CAIDP webinar, so a couple of quick words on CAIDP, and then I'll introduce you to our different speakers. CAIDP is a membership-based organization that promotes the services of Canadian development professionals internationally, and we provide a forum for members to exchange professional information and engage in professional development. We also promote the interest of our members. So my name is Jennifer Deneby. A warm welcome again to everyone. I am the Technical Director for Gender Equality and Social Inclusion at MEDA, which is an Ontario-based nonprofit. I'm also a board member at CAIDP. So I'll be moderating this webinar, and I have three experts to introduce to you. First of all, our topic. So as you probably know, we are here today to talk about ethics and international development work in the age of COVID-19. We have three experts who are going to share their experiences on very different aspects of working in this new context. We have a fairly large number of participants. I see about 25 people. So what we're going to do is take questions in the question box. I hope everyone can see several, for me, they're gray and they're bands. And if you open up the one that says questions, you should be able to type a question into the question box, and hopefully I'll be able to see it and I'll give the question to one of our speakers. Some of you have submitted questions in advance, which is great. Thank you very much. We're going to get to as many of those as we can. And if there are questions that we don't have time to respond to before our cutoff at 11, we will post some additional comments on the CAIDP page. So watch out for those there. Also, finally, just a note that this webinar is being recorded, and the recording should be able to be posted on the website as well. So our three speakers. First, we have Scott Ruddock. Scott is the Director of Global Security at MEDA, so he's my colleague. He is a board-certified security professional with 15 years of experience, and he's worked throughout Africa, Asia, Central America, and the Middle East. Since January, Scott's been leading MEDA's response to the COVID crisis, and he's also the founder of the COVID Pandemic Canadian NGO Security Roundtable, which brings together heads of security for aid and development NGOs across Canada to share information and resources relating to COVID. Next, we're going to have Lawrence Tucker Gardner. He is Co-Water's Vice President of Risk Management, and he has over 20 years in the international governance, development, and humanitarian sectors. He was the founder and director of Safety and Security Committee for Lebanon, an integrated risk management platform serving over 100 stakeholders involved in the Syria response. Most recently, Lawrence has been the Global Security Risk Management Lead for several international development consultancies, bringing international best practice and intelligence design solution to traditional fields of safety and security. For Lawrence, COVID-19 has created both the challenge and the opportunity of building institutional acceptance of risk management approaches to an emerging risk. And last but not least, we have Dana Peebles. Dana has 39 years of experience in international development, and she is the founder and director of Cartini International, an award-winning social enterprise that specializes in gender equality, human rights services, evaluation, and youth programming. She's also served as evaluation team leader for 11 complex multi-country evaluations and the sole evaluator or team leader for an additional 16 evaluations. She's also conducted multiple workshops on results-based management and has worked in close to 50 countries around the world. So welcome to all of our speakers. Before we jump in, we want to hear from you. So we're going to post a poll question for you, the first of our polls during this session. Nicole, could you load up our first question? So please choose one of the responses, and I'm just going to let everyone read and respond to this. Can you show the results, Nicole? I can't see anything yet. Great. Okay, wow, that's a dramatic answer. So 88% of those that responded think that COVID-19 will fundamentally change the way that we do business. Great, thanks, Nicole. So you may or may not change your mind as we go through our presentations, but thank you very much for sharing that. So Scott is going to be our first speaker, and he's going to talk about how an organization like MEDA understands and assesses risk in operations. He's going to talk about risk to different stakeholders that we all work with. So Scott, I'm going to give you 5 minutes on the timer. Please go ahead.
Great, thanks very much, and thanks everyone for joining us, and thanks to CAIDP for this opportunity. When I was thinking about what I wanted to talk about, I was thinking it probably, at least at this stage in the pandemic, doesn't make sense for us to go over what we've done at MEDA and sort of the risk mitigation steps we've put in place. I think there's been a lot of information provided to development practitioners around that. I really wanted to concentrate on some of the issues that we've encountered and kind of the ethical issues that we've wrestled with as an organization in our response. And so one of the first one is at the beginning of the pandemic, as we were thinking about how are we going to respond in terms of our programming and working with our clients and working with our partners, we really stressed first the importance of adopting what we've come to term the first do no harm approach. Now that's often associated with medical practitioners, but I think it has a lot to do with the development field as well. Because the unique aspect with COVID, when I think as a security director, when I'm typically looking at risks, it's kind of a one-way transaction. When I'm thinking of risks, I'm looking at what could potentially befall or go wrong for one of our staff or one of our partners. How could they be involved in a road traffic accident? How could they potentially be involved in a medical incident, criminal activity, or something along those lines, and putting mitigation steps in place to protect them from that risk. A risk like COVID, an infectious disease, kind of turns that on its head because now we have a two-way risk. So when our staff are out interacting and working in communities, they're potentially exposed to the virus and the risk, but they in turn can also, if they are infectious, can actually pose a risk to the communities in which we work in. And with COVID, as I think as many of us know, is some of the unique things is it's highly infectious, and that it's also infectious for people who are either asymptomatic, showing no symptoms, which is about 40% of people who get the disease, or people who are pre-symptomatic. So before they actually start feeling sick, they could be shedding virus for several days and be infectious. So we've really put an emphasis in terms of developing our protocols around doing that first do no harm approach, because we're in a unique position, right? We're invited into people's homes. We have trust within our communities. We spend a lot of time on an acceptance protocol, being accepted within the communities in which we work. And we want to make sure that we don't violate that trust. So we've got good protocols in place that ensure that we can minimize the risk to our staff in getting exposed to the virus, but also minimizes the potential risk going the other way for us unintentionally becoming spreaders in the communities. The other issue we took a look at is kind of the ethics of medical scarcity. As the disease progresses, it tasks, as we've seen in the States and in Europe, some other places, it tasks the best equipped medical systems, just in terms of volume of patients, how sick they are, and how long they need to be in hospital. And then when we start looking at some of the places where we work that are resource constrained, that have got some challenges in terms of being able to offer definitive medical care on a large scale, is ensuring that how are we going to manage those issues of medical scarcity and how we've approached it. I think, I look at Africa as I think is a good indicator. You look at, for instance, statistics. South Sudan, that's the nation of 11 million, has actually got more vice presidents, 5 of them, than they have ventilators. They only have 4 within the country. There's 3 ventilators in the Central African Republic. There's in total in the African continent are less than maybe 3,000 ventilators available. And there's sort of really some challenges in terms of access to medical care. So for us, that was why it was so important that we put protocols and systems in place that enable us to stay as healthy as possible, because we, in terms of if we're out spreading the disease or we're ensuring those gaps, we're going to be adding to that, right? And the last one is dealing with the issue of when COVID comes back. And so that's been really important as we're now in the process at MEDA of starting to look at our projects that we put on hiatus, or we've suspended operations. We've been on a global work from home protocol, but we're now in the process of our field offices starting to look at ramping up, starting to do some programming. And one of the things that we've had to take a look at is how are we going to respond when COVID comes back? So not if, but when. We know that there's going to be waves of the disease and new surges, and knowing how we're going to respond, and giving our staff, our field offices, empowering them with the information to be able to make those decisions in terms of suspending or slowing down operations, as well as working with local governments. So for us, when we're looking at the ethical issues, really that's sort of the three that we've wrestled with and we continue to wrestle with, and the other practitioners that I talk with wrestle with as well. First of all, ensuring that we're doing no harm, that we are managing the risk both to ourselves as well as the risk potentially to the communities of people we serve. Second one is that we're mindful of the ethics of medical scarcity, that we're really mindful of that we're working in environments that can quickly become overwhelmed if there is a large-scale breakout of the pandemic, and being able to ensure that our response to that. And the last one is knowing how we're going to ethically respond to the other waves of the disease. So until we've got a vaccine that's widely rolled out, and until we've got treatments that are widely rolled out, we're going to be dealing with these surges and these waves. And that's going to be an issue that we, I think, as an industry, as the aid and development industry, we're going to continue to struggle with. That was my opening remarks. Thanks so much.
Thank you, Scott. Thanks very much. So I'd like to give you our next poll question. Nicole, can you load up the next poll? Wow. Okay, so not surprisingly, almost everybody thinks that it is a shared responsibility to consider different ethical issues and considerations in programming. Great, thanks, Nicole. Our next speaker is Lawrence, and Lawrence is going to talk about duty of care in the age of COVID-19. Lawrence, please go ahead.
Thank you, Jen, and thank you for everyone who's tuned in, and thanks, Scott, for some great opening remarks. I want to build a lot on what Scott's spoken about, and he's given us a lot to think about. So I was kind of moving into the area of not just how we Codewater experienced this, but looking across a lot of our colleagues within the humanitarian and development fields. And what are our duty of care requirements, or what are our duty of care challenges that have come up in COVID? And I really saw three kind of key questions that have emerged in the last 3 to 6 months of the pandemic. One of the first challenges was the risk at home concept. So we have a lot of people within the humanitarian and development field that work in a range of contexts, many of them very challenging contexts or unstable. But now we're having people in whatever context they are sharing a same risk exposure or same risk experience, and that being COVID, and how they look to the organisation and how the organisation would support them. And I'll take the example of Canada as a good one, and the UK as a good one. So staff and consultants that had experiences of going out into the field and going to the country projects and having a lot of coverage or a lot of support from their organisation, which is fair, that's the duty of care. We're now asking, well, what level of duty of care do I get within my own country? What is my experience here? And what we found was, and talking to colleagues across the field, what we found is one of the big things was there was a great requirement for communication and to understand what duty of care means, and that though the organisation or the company does care for you deeply, there are simple considerations, or there are limits in what we can do with people within their own country. And it's not an easy conversation to have, but it's definitely one that had to be had. And it had to be taken in light of what Scott also mentioned, doing no harm or medical scarcity, that we didn't draw out additional resources within some locations or some contexts to provide staff, to provide consultants a duty of care which was above and beyond what would be considered normal in that environment. So that was one of the key kind of duty of care questions that came up around COVID. The second one is, how do we operate globally with COVID and duty of care? And when I referenced that, I kind of referenced the divergence between different regulations. A good example is whereas in the Palestinian territories, up until recently, Ramallah was still open and offices were expecting to operate there, whereas conversely in Ottawa and Ontario, offices were required to be closed, or non-essential offices were required to be closed. So I came back again to that question of, like, what was our duty of care and how do we address it with COVID, and how do we seem to be balanced as an organisation looking at different contexts. The focus again was communication, and it had to be very much two-way communication to hear what the different countries or the different relative officers were saying, what their expectations were, and being able to explain what we could and couldn't do. And I go to the third part of that, and that's kind of, so those two elements of duty of care were looking back, how we dealt with duty of care within the headquarter or kind of originating country offices. We had to look at duty of care across different contexts and balance duty of care against national or regional regulations. And the third thing we really learned about duty of care with COVID, and this is looking forward, is the different requirements for clients or donors around international deployment. We've definitely experienced it. I imagine many organizations have been asking themselves these questions or preparing to answer. When do we send people back out? When do we kind of reinitiate that travel as travel is opening around the world progressively? And I'll probably speak to the three very different experiences we had, which would be Australian DFAT, UK DFID, and Canadian GAC. Australian DFAT actually came up first because of the criticality of some of the projects we had there. And what we found was Australian DFAT was requesting us to have an independent risk assessment for each and every individual that we were deploying. It sounds very onerous, and I must admit it did take a little bit of time to work on, but it gave us the benefit of getting ahead of what those questions would be that would be expected from client and donors. And going actually back to Scott's comment, what was very good, what was very healthy to see was one of the key questions was not just the risk to the person being deployed, but is the person being deployed now an ancillary risk? Are they possibly bringing COVID into the community, or are they putting additional demands on medical systems that are already stressed? So by having that, we managed to move those kind of series of questions or independent risk assessment and present that to DFID and the UK government, which seemed to work well. And the next stage is we're looking at doing something similar to GAC, to the Canadian government, when we look at those deployments. It's 5 minutes. I just kind of wanted to touch on those 3 points, which is one, the interesting lessons of translating duty of care back at the headquarters to people who weren't quite certain of what the company or the organisation could and would provide. The balance that we had to find in duty of care of saying, well, I understand that regulations may be different per context, but we still need to provide staff, consultants and our beneficiaries that level of duty of care. And the third thing looking forward for duty of care is how do we enact duty of care as people start to return to travel, both the duty of care for those travellers, but also the duty of care of the communities they're returning to. Thank you.
Excellent, thank you, Lawrence. So I'd like to go to our third poll question. Nicole, could you load up our third poll question, please? And let's see the answer.
Close share.
Oh, interesting. This one's a little bit more balanced than the response. So is COVID-19 a greater risk to your staff and programs than road accidents? 38% said yes, and 62% said no. Interesting. Okay. Great. Now, our third speaker, Dana, is having some power issues. So we're going to give her a second to come back online. And while she's doing that, I'm just going to give one of the questions that somebody submitted in advance. Oh, Dana.
There we go. Sorry, I had to switch to my laptop. There was a great big bang outside, and I figure one of the transformers went. Anyway,
okay. Welcome back. Your timing is perfect. So Dana's our third speaker, and she's going to share the perspective of individual consultants and smaller organizations that do not have dedicated security staff. So quite a different context. Dana, please go ahead.
Okay, thank you. Well, basically what's happened is I've been called upon in the past couple of months, or past 4 months, to submit bids for, in this particular case, for evaluations and putting together teams and looking at, all the different issues that came up as a result. And so what I wanted to do is to give you an overview of all the different issues that came up as we developed our proposals, because they were all things we had to consider, and which ultimately determine whether or not we're actually going to participate in the bid, what it's going to cost, how we're going to do it. So a lot of this is not rocket science, it's pretty common sense, but these were issues that came up. And I guess the first question, we looked at the terms of reference and we said, do we need to travel? How much of this work could be done remotely? A lot of it can. I mean, I think there's a tendency to throw people on airplanes really fast. But then, okay, let's say there is a need for travel. Then we looked at, is that travel actually possible? Is it possible from a legal perspective? There are very few routes are direct, so you're going through multiple countries, which means you're having to apply different rules in each country, and they're going to be in different situations depending upon what their response was. And could you actually get there? And once you get there, would you have to then go into quarantine for 14 days, which is a very expensive model for your client and not very useful. Might give you a very nice hotel for a little while, or maybe not if it's not a great budget. All of this sort of brought us to the conclusion for a couple of the evaluations that we bid on that it didn't make sense to have us count on there being a travel function for international consultants to start. And that meant coming up with multiple options. So I said, okay, well, if we can't travel, how are we going to collect the data that we need to do? How are we going to get this work done? And then we said, well, that means we're going to have to work with a combination of national consultants and the implementing partners. And so what are the ethical issues related to those? I think, again, all the same health issues that affect us, and I think the two-way risk issue that Scott raised apply to national consultants. We can't ask them to do things that we wouldn't do. We cannot, in any kind of good conscience, ask them to take risks that we would not ask of ourselves. So, we came up with a couple of options where you have travel in country or somebody who could only work on logistical support. In other words, helping you find the people to talk to, and you do as much as you can remotely, knowing that you're not going to get the same level of interaction and it's going to be a different type of data collection. And all of that has to fit into how you do your analysis. But even at that, then the other question that came up was looking at the implementing partners. If we're asking them who's going to hire that national consultant? That's people's time. Is that work that you're going to ask of the implementing partner? So is it an expectation of the funder that the implementing partner will give that time? To me, those are all ethical issues, because it's that expectation of what kind of support they're going to do. Just because there's a crisis doesn't mean that all of this gets offloaded on the implementing partner, nor does it all get offloaded onto the evaluation team or whoever is going. So I think it goes back to that whole question of being a shared responsibility. Who's going to pay for this, either in terms of time or in terms of the money it takes to pay for that time? And those sound like rather crass and sort of pragmatic issues, but they all came up as when we were trying to come up with our budgets, trying to figure out, okay, how much is this going to cost? And for the one evaluation, we put in a budget that was at the top of their actual list, because the conclusion we came to is that working through remote evaluation is more expensive. It's not cheaper. Although you're saving the airfares, you're spending a lot more time doing logistics, consulting back, communicating, because in order to communicate effectively in that kind of context, you really do have to communicate a lot more. And as you can see, there's all kinds of challenges communicating remotely, such as power failures. So then the other issue that then came up was, okay, how do we then protect the privacy of the people using our different remote platforms? So we're looking at remote platforms for conversations with, we're doing key informant interviews. We're often talking about very sensitive subjects. We don't want to put people at risk if those particular platforms were hacked. So for example, Zoom is a great platform. It's easy, it's accessible, anybody can use it. It is not secure. Government officials often cannot use, or not allowed to use, if they're back in office, they're not allowed to use Skype. They're not allowed to use quite a few of these programs. So you have to really negotiate which communications venue you can use that's mutually usable by each side, that is safe for both parties, and that will help maintain the confidentiality of the data. There are also some platforms where you can post your data remotely so that different members of the team would have access to it. Again, that security issue, that privacy issue, confidentiality is a huge one. That's going to happen no matter what kind, whether you're in COVID or pre-COVID, but it's become more of an issue now because more and more of us are working remotely. So those, and then we were looking at, again, let's drill down further. We do a lot of focus group discussions with beneficiaries of projects. And given the field that I work in, they're often women, and they're often women in very disadvantaged or vulnerable positions. How do we maintain first of all, how do we reach them? If you can't do a face-to-face focus group discussion, one, can you hold the focus group discussion at all? Two, if you do hold it, are you holding it by cell phone? Many people do have access to cell phones. But again, then it becomes a question of protecting their privacy. And then the other issue is, particularly if they're poor, is who's going to pay for their phone time? So that becomes an additional potential cost in terms of how you actually set up your whole process. And again, then you go through the different, an alternative is that you can interview people one by one. So it's not a focus group, but you're asking for the same questions of the same people, and you aggregate those kinds of processes. If you want to do a participatory process where there's a validation of the data that you found, again, you're adding in another whole layer. So in order to avoid it being a very top-down evaluation, you have to look at all those different steps. And if you want those voices counted, again, it comes down to what's the technology to help you do that, and who's going to pay for the time and sometimes the training, because as what we found out in one of the proposals we did is that we were going to have to train the implementing partners on how to use the new technology that we're all using. In some cases, they'd probably be training us, depending upon who's got the different skills. So those were all sort of different issues that we came up with. And then I guess the other one that came up for me was really the issue of the ethics of self-care. As an individual consultant, I guess I have a tiny social enterprise, but at the moment it's mainly me, and I bring in people as I need. I'm in a good position in the sense I've got lots of experience, so I get work all the time. But what if I was a younger consultant and maybe the work is further and farther between? At what point do I put myself at risk because I need the money? So it's that whole issue of needing to look after yourself so that you can also then look after others. So very much what both Lawrence and Scott have talked about, but I'm looking at it from that perspective of, okay, who's going to look after me if I don't have an organization behind me apart from myself? I have to work with clients that I trust. So it may mean I'm not going to bid on certain things because I don't know these people. I need to know that they've got my back if I do eventually go out again, which I'm probably not going to until there's a vaccine. But again, I won't send people out either. So it's a decision that I've made personally that I will not put anybody at risk of any risk that I would not take myself. And Dana, I can't have that. Yeah.
Thank you. I'm just going to get you to wrap up. Thanks.
Yeah. Anyway, that was it.
Perfect. Perfect timing. Great. Thank you so much, Dana. An excellent third perspective that's quite a contrast to Scott and Lawrence's. Okay, we're going to go to our last poll question, and then we'll go to some of the questions from people that have submitted them in advance. Nicole, could you load up our last poll question, please? Nicole, how's our response rate?
89% voted.
Okay, let's see it. Would you be willing to conduct evaluation work, and I should have said, or other international work outside of Canada before there is a COVID-19 vaccine? So again, fairly evenly split, just over half say yes, and just under half say no. Great, thank you. So a few questions now for our panelists. Scott, the first question's for you. And I think this relates very well to the poll question. A significant issue for many organizations is when expat or head office staff can travel. What conditions or prerequisites do you see need to be in place before such travel can open up?
Yeah, I think that's something that every security professional working for an aid and development organization struggles with. I know on the roundtable that I convene, that's a question that we get a lot of. And when we, back in March at META, when we went into our global work from home protocols, it was probably the first question we got is, well, when will this be over? When will we be allowed to deploy? So at META, what we decided to do is we've identified sort of 3 milestones within the pandemic that we took a look at, and then we said that we wanted to see good progress in place before we consider it. One was that there would be broadly available and accurate testing, and that would be 2 types of testing. One is for antigen, which tells you if you're actually sick with the virus, and the second one is for the antibodies, which tells you you've been exposed to the virus and that you theoretically have immunity. I know that there's some discussions within the medical research community on the level of immunity, but we're going on the assumption, like every other virus, that once you've been exposed, you have a level of immunity. So that was the first one. The second one was, when were there going to be good treatments available? So if someone gets sick, are there going to be medical interventions past what we currently have available, which is just comfort measures, right? So are there going to be medical measures and therapeutics in place for people who get the disease and then get sick? And the third one was, when are we going to have, that there would be a vaccine available? Now, we decided early on that we were not going to peg travel to a vaccine, because realistically, we know it takes a long time to develop and roll out a vaccine. Now, put brackets around that, this is unprecedented times. You look historically, in terms of vaccine development, the quickest vaccine development historically was back in the 1950s, is for the mumps, and it took 4 years to develop and push that out. Now, having said that, I mean, the technologies are so much more advanced. We've got 170 vaccine candidates in various levels of clinical tests right now. We've got 2 that are in sort of phase 3 clinicals. So when people ask me, in my personal opinion, I think we're about 6 months out from having a vaccine, and then we've got to produce it. So what we've said, though, is that we want to have good testing in place, and then we want to have some therapeutics, some drug interventions available that should you get sick. Once we kind of got those in place, I would feel comfortable with having our staff travel. Who knows? We could actually have a vaccine before we have those therapeutics, but that's kind of been, at this stage, is kind of the litmus test for us.
Great, thank you, Scott. So my next question is, Lawrence, for you. How are other clients and donors dealing with duty of care aspects of programs with COVID-19? And what are some of the better resources that are out there for global risk assessment?
Okay, yep. So that's a good question. I'll refer to our experience, which is probably the 4 key client donors that we interact with, and that being obviously the Canadian government, the British government, the Australian government, and then the World Bank group, with a little bit of work for kind of millennial goal. We found 3 very different kind of responses. And I'll just give you a quick overview, if I may. We found that the Australians, kind of much in line with how the Australian government was dealing with COVID in the country, is it withdrew. It kind of accepted programming would stop or would be minimised to national staff. It definitely didn't want to see any further programmatic expansion for a period. And it did want everything to stay at a stable or steady state. So you can say it was a risk-adverse approach or a risk minimisation. Interestingly enough, from DFID, from the UK government, we were asked to pivot our programming towards COVID. So it was actually, we had to look at programs throughout the world, wherever they were, whatever they might be doing, whether it be taxation or girls' education or a health-based project. They said, right, what within that framework can be COVID particular? So it was really kind of using not necessarily the opportunity, but reorienting contextually around that, which we found was quite empowering, because then we reintroduced duty of care, whereas with the Australians, duty of care was just addressed in a minimised risk approach. With DFID was, well, okay, we reintegrate duty of care with a change in programmatic approach. And if I talk to the last 2 kind of clients or donors, the Canadians had a more kind of, not dissimilar to Australia, was a little bit kind of reduced risk or avoid risk, bringing it back. But in terms of the programs, we were told that humanitarian programs would take precedence, which makes sense. And then finally, interestingly, less so from the World Bank group, but definitely from MCA, MCC, was that because a lot of the millennial goals orientate around big shifts in infrastructure, access to water, access to power, was that they needed a complex and quite a consistent process of how infrastructure would continue to go forward. Infrastructure would continue to go forward in the case of COVID. So very much of this is the new normal, you adapt to it. So we saw 4 quite different kind of references from the donors or clients, and we had to adapt it. And it goes a little bit back to what's, we've all talked about, it's one pandemic, but it's 191 different contexts that we have to work with it in. And the last thing I kind of wanted to say about COVID resources out there is, I won't obviously plug any provider or not, but we actually found there's quite an emerging business of data platforms, of access to platforms, and the whole role of the platforms is to detail regulations, aviation capability into the country, current caseloads, stress testing, the medical infrastructure. And just having that information, we're not necessarily at the point where people are going back, but having that information kind of built a lot of confidence back in the projects, that we were aware of what was going in their context. And it's built a lot of confidence back in headquarters that, okay, yeah, we're taking an intelligent approach to this. We're taking an informed decision, very similar to what Scott said about how meter was making very informed decisions about when they'd return to travel. So it's a really good question, two very interesting kind of, I'm just giving our experience, but I think there's some value in that.
Great, thank you, Lawrence. Excellent. Dana, a question for you. What has been the biggest challenge for you in developing new ways of conducting evaluation or new ways of working in the COVID context? And what have been some of the positive things that you've found?
Well, the challenges, I think some of them I've already talked about. I think the main thing is, and I'm going to speak specifically about evaluation work because that's where I've really thought it through. And also because I'm working on an evaluation which we had to finish. We started it pre-COVID and had to finish it afterwards. How do you get good data? How do you treat people fairly are the biggest challenges. And trying to figure out how does, I guess the other big challenge was the one I mentioned is how do you get, I'm going to put it very bluntly, how do you get funders and clients to understand that to get accurate data, to treat people fairly and safely is not cheap. It's not a question that we're trying to say spend, 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 but I know I personally will not work on some things if certain protocols are not put in place, and I'm not willing to work on an evaluation where I can't guarantee some kind of validity of the data. So that to me is the challenge. And I think it's a negotiation process and it's a communication process. And that communication is always a challenge, I think, with in any kind of client consulting relationship, to make sure everybody understands the same thing, that you're going after the same thing within the resources available. To me, the positive things that have been coming out of it, I think there's a real opportunity now to really work on building national capacity. I think we've been traveling too much. It doesn't have to be international people who come in and tell people how to do things. Yes, we have certain areas of expertise, but a lot of this can be shared in this kind of a format. And I think it's a chance to really grow and do things in a different way. And yes, that means taking time to ensure that there's training where there are gaps, or if you're mentoring people who have simply have less experience. And I think to me, that's the really golden opportunity, is that opportunity to step back and let other people take the lead.
Great, thank you, Dana. It's nice to be thinking about opportunities within such a complex and frankly longer lasting than we expected crisis. So I don't actually see any questions in the question box yet. If you do have questions, please feel free to post them. I've got a few additional questions that people sent us in advance, so I'm going to go through a few of those now.
Actually, we have two questions.
We do? Okay.
Yes. The first one is, in your experience, is there a difference of access to COVID responsive technologies between women and men?
Great, I'm adding that to my list. And Nicole, what was the second question?
I'll just get to it. Here it is. Thanks, Dana, for your presentation. These are real issues for individual consultants. Even some UN organizations do not integrate COVID restrictions in their TORs. I saw recently a footnote indicating that the pandemics might be an issue, which we could be considered on a case-by-case basis.
Yeah, I've seen that one.
Great, okay, thanks. So some reinforcement for Dana's comments and the need to consider each situation specifically and individually. Okay, so Lawrence, I'm going to give this question to you. How do we get governments, different governments, the Canadian government, but others as well, to pay attention to international development in this time of crisis?
Yeah, look, it's a really good question, Jen. And, you know, we kind of like to think the easy answer is advocacy. It's kind of how it works. But I think there's, and I really agree with Dana about this idea of opportunities. So COVID takes up a lot of space. It sucks a lot of air out of the room. In any given discussion, whether it be programmatic or whether it be operational, it tends to dominate the mindset at the moment. But I think if we look at what DFID did as a very interesting example, saying, well, the programs are still out there. We have a capability. We understand that there may not be travel, but we do have kind of these investments or relationships. with communities, with national governments, with regional organisations. Let's use that as a COVID response. And I think there's a lot to be said about this idea in international development that what we do, yes, is of good and is for the betterment of humanity, but it does have a national value to it, that if we do help stabilise communities, if we do enhance education in communities, if we do enhance access to healthcare, it has a net benefit for that community, for that nation, and it also benefits a client or a donor nation. I think we can approach COVID in the same way, that by saying, look, COVID will occur, but it could be a destabilizing influence if we don't still have this attention towards international development. I'm thinking myself now about the Pacific, or I'm thinking also West Africa. You know, if we don't maintain that kind of growth in terms of good infrastructure, in terms of good public finance management, access to education and access to water, even in the case of COVID, then COVID becomes a problem for us. And I think that's the way that we'd approach national governments, or that's the way that we could advocate to them, saying, look, the programming we do is good, and it could be even better because we are facing COVID.
Great, thanks, Lawrence. And actually, I can suddenly see the questions, which is great. Okay, so one of our other questions that was submitted in advance, Dana, I'm going to give this question to you. This is a slightly different angle on the idea of ethics, but I think a really, really important one that a lot of us have been reading about or hearing about. How do we address the issue of women's unpaid care work in the context of COVID-19?
Okay, I was thinking about this one, and I think they really, starting off with the, I think it's really important to look at the impact of COVID, the differential impact of COVID, not just on women, but on various groups, but women in particular, in terms of unpaid care work. It's meant, and I think this has been in both industrialized countries and countries that are poorer, more women have lost work than men. Partly because of having to be responsible for care work. So if you have a two-income family, in order to survive, often you're going to pick the income that is higher, which tends to be the male income. I'm making gross generalizations here because it's not always the case. Or the women themselves were in unpaid precarious work, and they were more likely to lose their work. And because they are at home, therefore, all that work falls to them. So I can actually think of a number of instances where you have a two-income family and the woman's not working because she has to look after her child. So I think it's very important to understand that as a starting point. Not just your child, could be elderly parents, you know, whatever the care work is, but it's generally family responsibilities. What that means is, one, you have less access to income, you've got less access to financial independence. There's a whole ripple effect in terms of if you're stuck at home doing care work, if you're stuck at home, period, as a woman, you're much more susceptible to domestic violence. There are going to be greater economic stresses, so the violence is going up. They've come up with, I think, what is the symbol? I think it's this. If you're online with somebody, if you have access to being online, in reference to that other question, to show that there's something going on in your house and you need help. That isolation is very important, but I'm also thinking of it from the perspective of voice. If you're invisible at home looking after children and you don't have access to these kinds of electronic platforms, if you're not connected in different ways, then how are your needs counted? How are they even perceived as being a need? It doesn't mean that you're being ignored on purpose. I think that's the whole thing about systemic discrimination of any type. But the point is, you're not visible. So I think what COVID has brought out is just how invisible some people are. And just the sheer volume of the crisis has made glaringly clear the vulnerabilities. The question is how we're going to address them. So I think in terms of any kind of work that we do, to keep those things in mind. I'm doing a series of technical guidance notes for the EU right now from a thematic perspective on COVID. And we're looking at it from the gender, age, and diversity perspective. And I would say you do that for anything you do, not just because you're a gender specialist, but in anything that you do. include that analysis. Who is not at the table? And why aren't they at the table? Because of COVID. This is sort of a very sort of blanket statement, but it's making sure that their voices are counted.
Great, thanks, Dana. And you touched on several extremely important topics there. There's a lot of documentation on the specific gendered impacts of this crisis, and that's a lot of what we've been reading. Thank you. Scott, a question for you. In the absence of a vaccine, how do we choose who we send overseas? And in fact, should we be trying to send anyone overseas?
Yeah, so obviously it's a question I think a lot of organizations are wrestling with. And at META, as we're slowly ramping up our operations and we're looking at staff from our head offices wanting to head out, we're starting to wrestle with that too. So what we're looking at, obviously, it's going to be individual risk appetite as well as the own risk assessment that we can do. So when we're looking at, we know that there are people in certain age categories, and we know that there are people with certain medical conditions who if they contract the disease, they tends to be considerably more severe than others. So I think there needs to be some sort of screening mechanism in place that enables people to, in a valid way, be able to make an informed consent around risk. So if I've got a couple of examples, if I've got someone who's 25 in quite good health versus someone who's perhaps in their 60s who's got an autoimmune disorder, I know that one's going to be riskier than another one. So you need to provide that information. You need to let people know. I think one of the really important roles that we played at META is sort of being a curator for information. So there's a lot of misinformation, unfortunately, because of social media, so it's out for the disease. And so we've been a curator. So we provide informed, evidence-based information for our staff. So in the absence of a vaccine and people wanting to travel, I think that's going to be a key, is doing individual risk assessments, providing people with quantified evidence-based rationales for risk, and allowing the organization to make a risk decision, but also allowing the individual to make a risk decision as well.
Great, and the element of choice is, I think, quite important, as well as risk assessment. Great, thanks. We're getting some great questions in the chat box here. I am going to pose this question to Dana. Sorry, there's a lot of scrolling that I have to do to read the question. So Dana, the question is, when it comes to data collection, is there any shift on what is considered good enough? I see a tension between the push for methodological rigor and the risks imposed by COVID. So an ethics perspective on this would be useful.
Actually, we're dealing with this right now in the evaluation I'm working on in the Middle East. And we had focus groups planned for 3 countries. We were able to do them in Jordan. We weren't able to do them in Palestine or Egypt. In Palestine, we were able to interview 4 women individually. Is that enough of a sample? No, but it did give us some indication of some important issues. So we were, and we've stated in the limitations of the evaluation, these are qualitative responses. We don't have numbers to back them up. In Egypt, we weren't able to do the focus groups at all because it would have been putting too many people at risk, and it was very complicated because everybody's working in factories. So I guess in short, yes, the rigor has diminished, but I think there's still ways to use the data that you get to extrapolate some of your findings and conclusions, as long as you're very clear what the limitations are and you state those up front. And you also always triangulate your data anyway. So if we couldn't do a focus group, then we talk to the key, different stakeholders, talk to more than one stakeholder. And as I said, the alternative is to do individual interviews with a small sample and really focus more in depth.
Great. So balance, triangulate, and state the limitations up front.
Yeah.
Great.
And also check it with your client.
Yes, that's important.
To see what they'll accept,
Exactly. That's important. Thanks. Okay, I'm looking at time. We've got time for one more question. There's definitely more than one question left here in the question box. So we're going to try to post answers to anything we weren't able to get to today on the CAIDP webpage. And Nicole, I'll talk to you about that afterwards, about how we get that information out to people. So the last question is, the majority of attendees thought that this, and by this I assume we mean COVID-19, is a game changer. what, in your view, will our sector look like in terms of operations 6 months, 1 year, 2 years down the line? Lawrence, I'm going to start with you on this question. So basically, what's the future of our sector in light of this?
Okay. Well, I think Dana's made a very good point earlier about this. There's been a lot of talk in the development and humanitarian industry of the last 5 to 10 years about nationalisation or better use of the capacity build that we build in the countries that we go to, and we being whoever is moving internationally. I think that's going to come to the fore. I think it's no longer a concept or something we're striving for. It's an absolute necessity to working. So one is that, and I think building on that, and I've been thinking about this, is actually a greater kind of concept of regionalisation. So as you would have seen, there's a lot of discussion of travel hubs or areas within a designated number of countries. So now if I'm looking for a capacity for Mali, I might turn to Senegal, or I might look at Cameroon, like another regional part. And I think that's something that we'll definitely see in the next 6 to 12 months, is moving away from, moving into, okay, this is our bubble of activities, so ergo, where's our capacity there? I think the other big change that we will face with COVID is that, and this is probably not the best note to end on, but we're going to see a real strangle in terms of the money that's available for development, and that's just a product of downturns of GDP. Most of the, even when you look to the UK is a good example that it's trying to achieve its 0.7% of GDP goes to development. The UK is looking at between 2 to 5% gross GDP, reduction, and that means how good your aid budget is, your aid budget is significantly reduced. So I think we're going to see a period where we have to be quite frugal. We have to be very careful how we conduct our activities. And going back to Dana said, remote doesn't necessarily make it cheaper. Taking an airplane flight out of a budget is not the big budget change. It's a lot of the modalities. So there'll be a lot of pressure, I think, in the industry to look at more innovative or more kind of value for money approaches on how we do that. And that'll be my 3 kind of key big changes that we're going to see.
Great, thanks, Lawrence. In the interest of time, Scott, do you have about 30 seconds that you'd like to add to that? What do you see changing in the industry?
I would see the adoption of more virtual technologies, especially at the field level. Field level, by necessity, has had to push out a lot of interventions using mobile phones and digital technologies. If innovation, if necessity is the mother of invention, this really has shown that that we can do a lot of the program that we need to do using technologies and virtual technologies. So I think that'll be the big shift.
Excellent, thanks. Dana, 30 seconds on this as the last word on this question.
I think I'm going to put in the gender risk hat on that one. There was a question about access to technology, and I think the answer is yes, there is a differential access. So again, if we're going to be working more with remote technologies, which we are, then we need to make sure that it's an equitable access. And it's not just gender, it's also rural, urban, age differentiated, youth, etc. So I think that's an important part to look at in the future as well.
Great, thank you so much. And thanks for tying in that earlier question, Dana. Bonus points for you. So just to wrap up, what I wanted to do is highlight a few of the key points that our speakers have made over the course of this webinar, and then I'll redirect everyone back to where we're going to hope to post answers to additional questions and some resources. So Scott at the beginning talked a little bit about the do no harm approach and emphasized the two-way nature of the risk and the risk management that's required in this, frankly, fairly unique situation, at least to date. And also talked about the ethics of medical scarcity. So the implications of continuing programming, of continuing to send people to different places, and what that might have in terms of impact on those people and the locations. Lawrence talked about making sure that there is shared risk. There is additional duty of care that's involved in the activities that we're doing. And that there are a big variation in things that different donors are requesting and allowing and are thinking is possible. For example, doing individual risk assessments for each person that is involved in work right now. Dana talked about the sort of individual and smaller enterprise response to this, and when considering new work, how can work be done differently? Can it be done remotely? What some of the ethical issues are there? If we are not doing the work ourselves, but placing local consultants or perhaps regional consultants in these situations, there are still ethical considerations, and that it's really important to continue to think about that. Privacy, data confidentiality for our clients remains paramount and is slightly different given some of the different platforms and methodologies that we're using here. And I guess I would just finish by saying we've probably read a lot about how this is a very gendered pandemic, but that it affects different people very differently depending on who they are, where they are, and what their experience is with the conditions around them. To finish on a potentially positive note, some of the opportunities that were mentioned are that the restrictions in travel and in our ability to move around may mean, or are meaning and may mean in the longer term, that we're able to make more and better use of national talent and regional talent. So I think that's a really good goal for the future and for the future of the industry, to recognize that there's a lot of capacity in the places that we're working in, and we don't always need to go there. And so in the short term, I think Dana mentioned, or perhaps Lawrence mentioned, building in time to do training now or whenever possible in order to really maximize that local and national and regional talent. So that was a very quick summary of what we've talked about. As I said, we'll make resources available on the webpage, and please come and see the answers to questions we may not have gotten to. But thank you very, very much. I still see that there's lots of attendees online, so thanks for sticking with us. And big thanks to our three speakers. Thanks, Scott, thanks, Lawrence, and thanks, Dana. Thank you very much, everybody.